Nearly 40% of sudden natural deaths happen without a single witness. A person simply collapses behind closed doors, leaving behind a body with no external signs of trauma or struggle. The law does not guess. Under the Bharatiya Nagarik Suraksha Sanhita, or BNSS, this lack of evidence triggers a strict legal mandate, an immediate police inquest to determine exactly what happened. To determine whether the death was caused by hidden disease or unseen foul play, the forensic pathologist must bypass the skin and look directly into the engine of life itself. That engine operates through 3 layers. There is the outer epicardium, the thick muscular middle known as the myocardium, and the smooth inner lining called the endocardium. Forensic records provide exact parameters. A healthy heart averages 300 grams for males, 250 for females. They also detail required wall thicknesses. Atria are 1 to 2 millimeters, while the left ventricle is 10 to 15 millimeters. These exact measurements form the pathologist's baseline. Physical deviation from these numbers points towards system failure. The most frequent biological failure is hypertrophy. When a patient suffers from high systemic blood pressure, the heart muscle is forced to overwork against that resistance. Like any muscle forced to lift heavy weights, it bulks up. In the human chest, extra mass is dangerous. Once a heart's weight exceeds 420 to 450 grams, it crosses a lethal threshold, drastically increasing the risk of sudden death. This pathological cross-section shows concentric hypertrophy. The left ventricle wall thickens inward, shrinking the internal chamber and restricting the volume of blood it can pump. This creates a fatal biological paradox. The sheer mass of overgrown muscle outstrips its blood supply. It turns an outwardly strong heart into a highly unstable organ. To maintain muscle mass, the heart needs dedicated plumbing. The left and right coronary arteries supply oxygen, originating directly from the aortic sinuses. The right artery feeds the posterior heart, while the left splits into the circumflex and left anterior descending, or LAD. The system operates on a principle called coronary dominance. In about 70% of the population, the heart is right dominant, meaning the right coronary artery supplies the crucial posterior descending branch. Under normal conditions, this network perfectly balances oxygen delivery. But because these pipes do not overlap significantly, they are vulnerable to a single-point blockage. Sudden cardiac death rarely occurs from a minor narrowing. The threshold for disaster usually requires a severe stenosis, a narrowing of the artery by 75 to 85% due to atherosclerosis. When that narrowed pipe finally closes, it happens in one of 2 ways. Either a vulnerable plaque deposit suddenly ruptures, triggering an immediate blood clot, or a hemorrhage inside the plaque wall swells the deposit until it pinches the pipe shut. Location dictates lethality. Because the left anterior descending artery supplies the massive left ventricle, the heart's main pumping chamber, a sudden occlusion here earns the clinical nickname, the Widowmaker. There is also a hidden structural trap called myocardial bridging. Instead of resting safely on the surface, an artery is formed diving deep into the muscle. With every beat, the heart forcefully clamps down and crushes its own blood supply. Whether choked by a ruptured plaque or crushed by a muscular bridge, the mechanical plumbing failure inevitably triggers a catastrophic electrical cascade. A blocked artery does not just starve the muscle. It triggers a fatal electrical short circuit governed by the body's autonomic nervous system. In moments of fear or extreme exertion, the sympathetic nervous system releases catecholamines, adrenaline-like hormones, designed to aggressively spike the heart rate to meet the body's demand for oxygen. When those catecholamines hit an oxygen-starved ischemic patch of heart muscle, the cells become highly unstable. The organized electrical rhythm breaks down into ventricular fibrillation, a chaotic, rapid quivering that pumps absolutely no blood. Conversely, the parasympathetic system can overreact to certain physical traumas. Overstimulation of the vagus nerve causes a profound drop in heart rate, resulting in a fatal reflex asystole, or flatline. In both of these scenarios, the final biological event is a massive electrical storm that permanently disables the human pump. We have to take these anatomical vulnerabilities and apply them to the real world. What happens when an outside human force pushes this fragile, overloaded system over the edge? Consider a person harboring severe, undiagnosed 75% coronary stenosis. They get into a minor physical altercation, a simple shove to the chest, or a highly aggressive shouting match. The assault triggers an invisible biological chain reaction. The sympathetic nervous system fires, instantly flooding the compromised heart with catecholamines. The oxygen demand spikes instantly, but the narrowed Widowmaker artery fails to deliver. The electrical system crashes into ventricular fibrillation, and the victim drops dead on the spot. This creates a medico-legal paradox. Can an assailant be charged with homicide for a minor shove that would never have harmed a healthy person? Under the Bharatiya Nagarik Sanhita, the answer relies on the legal doctrine known as the eggshell skull rule. This rule dictates that an assailant must take their victim as they find them, including all their hidden internal frailties. The burden then falls entirely on the forensic pathologist. They must prove through biological evidence that the stress of the assault directly precipitated the plaque rupture, or the fatal arrhythmia, linking the physical act to the biological death. Forensic medicine translates microscopic biological failures into the hard factual currency of criminal justice.